Welcome to the Deep Dive, where we unpack complex sources to give you the essential knowledge fast. Today, we're diving into a topic that is, well, notoriously difficult to diagnose: invasive lobular carcinoma, or ILC. We're drawing from a really comprehensive imaging primer published in RadioGraphics, and it's a phenomenal guide to understanding this very subtle form of cancer.
And our mission today is pretty laser-focused.
Yeah.
We really need to understand why ILC is so elusive, both when a doctor examines a patient and, when radiologists are looking at an image.
Right.
I mean, ILC is the second most common invasive breast cancer. We're talking 5% to 15% of all cases. Yet the sources just repeatedly emphasize that a missed or delayed diagnosis is a significant risk. So we're connecting the dots between its unique cellular structure and its, frankly, frustrating appearance on screening.
That delayed diagnosis risk is what makes this so crucial for you, the listener. If this cancer is so common, why is it so hard to spot? Okay, let's unpack this. What is the fundamental difference in the biology of ILC that makes it so tricky compared to, say, invasive ductal carcinoma IDC, which usually forms a nice, solid lump?
We have to start right at the cellular level. The defining characteristic of ILC pathology is it's rooted in two factors that really dictate everything else we see radiologically.
Oh.
First, the cell arrangement. These are small, uniform cells that don't crowd together. Instead, they infiltrate the tissue in this loose, sort of circumferential pattern around the ducts and lobules. It's often described as the classic single-file pattern.
The single-file pattern, so like they're lining up one by one.
Exactly. Think of them less like a dense military formation and more like individual hikers spread out across a large field.
That makes sense conceptually, but what keeps them from clumping together in the first place?
And that brings us to the second, and I'd argue most important, biological factor. ILC involves the loss of a crucial cell adhesion molecule. It's called E-cadherin.
E-cadherin. So, if I'm getting this right, that's essentially the cellular glue.
That's the perfect way to put it.
So if you lose that glue, the cells just can't stick to each other to form a cohesive ball.
Precisely. Because they lack that adhesive quality, they can't aggregate into a solid high-density mass. And this leads to the next major problem. The body's reaction to ILC is dramatically different.
How so?
In most typical cancers, the tumor provokes what we call a desmoplastic stromal reaction.
That's a mouthful.
It is, but it just means the body tries to wall off the invasion by building dense fibrous tissue around it. And that reaction is what results in that discrete, hard lump we can typically feel or see on a mammogram.
I see. And because ILC doesn't form a clump, it doesn't provoke that intense wall-building reaction. So the cancer is essentially hiding because it doesn't force the body to build a defensive structure around it, which would make the clinical findings inherently subtle.
Exactly. Instead of a discrete, sort of marble-like mass that a woman or clinician might feel, the clinical signs are much more ambiguous. The sources detail findings like a vague area of palpable thickening or subtle swelling that just seems off.
It's so counterintuitive. You're expecting a distinct knot, but you just feel a general firmness. The sources also mention structural changes, right? Things that signal an underlying issue, like dimpling of the skin or changes to the nipple shape, like it becoming inverted.
Yes, and they even bring up the unsettling symptom of a shrinking breast appearance over time, though that one is tricky because other, benign issues like fat necrosis can also cause that same appearance.
And what about who gets this? Is there a typical patient profile?
There is. ILC tends to be diagnosed in slightly older women. The median age is around 57. We've also seen its incidence increase over the last couple of decades, which is possibly linked to the increased use of hormone replacement therapy.
And the prognosis?
Well, the classic variant of ILC generally carries a favorable prognostic profile. It's usually low grade and positive for estrogen and progesterone receptors. But, and this is a big but, it is still considered highly metastatic. And we also have to acknowledge the aggressive nature of what's called the pleomorphic variant, which has a worse prognosis and is much harder to treat.
Given that ILC's whole identity is based on stealth and infiltration, traditional screening must be severely challenged. What does the data tell us about the success rate of standard mammography?
Mammographic sensitivity is, well, it's highly variable. It ranges anywhere from 57% up to 81%. But the critical point is the failure rate. The sources confirm that between 8% and 16% of ILC cases may present with a completely normal or benign-looking mammogram.
16%. So a 1 in 10 chance, or nearly 1 in 6, that this invasive cancer is just missed entirely by the standard screening tool. That's a massive gap. And why is that failure rate particularly dangerous for ILC?
Because ILC, due to its infiltrative growth, can be much more widespread than that initial imaging suggests. A delayed diagnosis here isn't just a matter of waiting. It means the tumor has more time to grow diffusely through the breast tissue and, potentially, metastasize. The unique pathology makes the disease just harder to quantify early on.
So when mammography does pick it up, the images aren't what we typically think of as a tumor. No dense white starburst. What are the subtle cues a radiologist is looking for?
The signs are definitely subtle. The most common finding, seen in about 44% to 65% of cases, is still technically classified as a mass, but it's one that is highly irregular. It has what we call spiculated or indistinct margins. In contrast, those nice, round, easy-to-measure masses are incredibly rare. We're talking only 1% to 3% of cases.
And the second most common feature is maybe the most elusive: architectural distortion. Can you explain what that looks like? Because that sounds less like a mass and more like a sign of hidden trouble.
That's precisely right. Architectural distortion, seen in up to a third of cases, is where the tissue appears distorted or pulled inward, like fabric being subtly gathered or wrinkled in one area. There's no dense center, just a sense that the internal structure is being disturbed by unseen forces. It's a telltale sign of those single-file cells pulling on the surrounding ducts and ligaments.
And then there's asymmetry. I read that ILC is often characterized by density that is equal to, or sometimes even less than, the normal breast tissue.
Yes, and that low density links directly back to the low cellularity and the lack of that desmoplastic reaction we talked about earlier.
It all connects.
It really does.
Right.
And this asymmetry is frequently seen on only one view. Classically, it's the craniocaudal or CC projection. That's the top-down view of the breast. The tumor can be so diffuse that the standard side view might completely miss the subtle change in volume that the CC view captures.
So what does this all mean for the treating physician? The fact that the tumor density is so low and that mammography frequently and significantly underestimates the true tumor size, it tells us we simply can't rely on screening alone for accurate surgical planning. We need better maps.
Absolutely. This inadequacy pushes us squarely into the multimodality approach, starting with ultrasound, or US. US has a wide sensitivity range from 68% up to 98%, and it's crucial because it's superior to mammography for detecting multifocality.
Meaning multiple spots of cancer in the same quadrant.
Exactly, and multicentricity, which is cancer in different quadrants.
And what's the signature look for ILC on ultrasound?
The most common U.S. presentation in about 60% of cases is an irregular mass with angular margins, usually showing a hypoechoic or heterogeneous echo pattern. But the key diagnostic sign that often just screams ILC is significant posterior shadowing.
Okay, we need to unpack that. Posterior shadowing. What does that actually indicate to a clinician about the texture of the cancer?
In simple terms, when the ultrasound sends sound waves, they travel through the tissue. In a normal mass, the waves might be reflected, creating a bright spot. With ILC, those infiltrating cells are so spread out, they cause the sound waves to scatter widely and diffusely. This scattering effect creates a large, dark shadow directly behind the area of suspicion. It's an indirect sign, a shadow where the sound energy went missing, and it is a powerful clue.
So the body of the tumor might be hard to see, but its effect on the sound waves is often what gives it away. But I imagine even US can have blind spots.
It does. A key pitfall is that ILC can manifest only as focal shadowing, with no discrete mass visible. Or in about 10% of cases, it can be entirely sonographically occult, just invisible.
Wow. So if mammography struggles with density and US can have these occult areas, where do we go for the real definitive map of the disease?
We go to MRI. Magnetic resonance imaging is considered the single most accurate modality to assess the full extent of the disease in a new ILC diagnosis. With a sensitivity between 93% and 95%, it provides the resolution and detail you just have to have.
That high sensitivity is so critical, especially when we hear that ILC is twice as likely as IDC to be multifocal or multicentric. MRI must be absolutely essential for surgical planning then.
It is. It's superior to both mammography and US for size estimation, and crucially, for detecting bilateral disease cancer in both breasts, which ILC is also more prone to. Now, while the common MRI manifestation is an irregularly shaped mass, the most telling sign of ILC's infiltrative nature comes from something called non-mass enhancement, or NME.
NME, it's a technical term, but it seems to be the visual proof of that single-file pattern we started with. When we see non-mass enhancement, what exactly are we looking at?
NME is detected in up to 40% of ILC cases, and it is a game changer. It means the cancer isn't showing up as a solid ball. Instead, the contrast dye is lighting up a diffuse area of tissue, outlining the widespread cells that have infiltrated the breast like a creeping fog. It often reveals the true, much greater extent of the disease that was simply invisible on other modalities. This is the radiological manifestation of that E-cadherin loss.
That makes the visual distinction so much clearer. And we can also use MRI to look at kinetics, right? How the contrast dye washes in and out of the tumor. Does ILC show a different kinetic signature than IDC?
Yes, and it's a valuable distinction. When IDC tumors grow, they aggressively recruit new blood vessels, which results in a very rapid wash-in and wash-out of contrast dye. ILC, being more diffuse, tends to have less organized blood vessel networks. So ILC tumors show maximum enhancement at a significantly slower rate than IDC, and a smaller percentage show that aggressive delayed phase washout.
That high sensitivity, 93 to 95%, is incredibly impactful. The source notes that MRI findings lead to a change in the clinical treatment course for a massive 50% of ILC patients, specifically leading to changes in the actual surgery in 28% of cases. It's the essential tool that stops surgeons from missing widespread disease that would otherwise lead to a recurrence.
And this brings us to the bigger picture and the outcome of the disease. Despite its generally favorable hormone receptor status, ILC is highly metastatic. The sources state that 2/3 of patients eventually have metastases, and the patterns are incredibly distinct from IDC.
This is where ILC gets even trickier. While both ILC and IDC metastasize to places like bone and liver, ILC has this unusual pattern, targeting sites you don't typically associate with breast cancer.
That's right. ILC is far more likely to metastasize to the peritoneum, that's the membrane lining the abdominal cavity, and the retroperitoneum, the space behind it. It also frequently targets the GI tract, the urogenital tract, the lining of the central nervous system, the leptomeninges, and even the heart muscle, the myocardium.
That is a startling list. Why the GI tract and the peritoneum? Is that related to the single-file nature of the cells and how they travel?
It's suspected that the individual, non-adherent ILC cells may have a unique way of migrating through the lymphatic or vascular systems, one that favors these surfaces, allowing them to spread along membranes and linings rather than forming large, solid organ masses. And the consequences can be unusual. Hydronephrosis, or kidney swelling, is listed as a common complication of metastatic ILC, which reflects that deep involvement.
So management has to account for this widespread, often multifocal nature and these unusual metastatic destinations.
Absolutely. Surgical excision with clear margins remains paramount. But because ILC is so frequently multifocal or multicentric, it's more likely than IDC to require a mastectomy. Beyond surgery, treatment includes standard radiation, systemic chemotherapy, though ISC is generally less responsive than IDC, and crucially, long-term hormone therapy, given that high rate of being ER/PR positive.
This deep dive has really highlighted how the fundamental biology of ILC, that subtle, single-file nature of the cells and the loss of E-cadherin, dictates everything. The difficulty of its detection, the extent of its spread, it really is the cancer that hides in plain sight.
And what's fascinating here is the power of technology to overcome that elusiveness. While mammography provides those crucial initial cues, often just through subtle signs like architectural distortion or asymmetry, it is MRI that ultimately provides the indispensable roadmap. It accurately depicts the true extent of the disease through non-mass enhancement, which is just vital for effective surgical planning and long-term prognosis.
Thank you for joining us for this deep dive into ILC. For you, the listener, here is a final provocative thought built directly from these sources. Given that ILC's metastatic pattern is so distinctly different from IDC targeting the GI tract, the peritoneum, areas outside of typical surveillance, how might the standard follow-up protocols currently used for breast cancer be fundamentally adapted to catch these unusual non-bone metastases earlier when they might still be treatable? Something critical to mull over until our next deep dive.